Morning, everybody. I'm just going to share my slides in a moment. I'm Sarah Humphrey. I'm a GP by background, and since it's a Sarah double act, my colleague Sarah Mitchell-Gears will be coming in to do the last third of the presentation. She's principal pharmacist for older people at the Care Trust. So let me share some slides, and what we're going to try and do is go through the slides. It'll take about 25 minutes. Think of your questions, pop them in the chat box, and then we'll come to those rather than breaking in, just because I can't see you once I decide to share my slides. So just 1 second. Get this right. Okay. So I'm assuming now I can only see now Jacinta in my bottom box, so she's going to be my conduit into you all. Jacinta, can you see everything? I can't hear you, Jacinta, so just put a thumbs up if you can see my slides.
Sorry. Yes, I can
see
hear
them.
you now, and I can see the slides. Thank you.
Perfect. Right, so what we're going to talk about today is understanding and responding to distress in people with dementia and reducing the use of anti-psychotics. So I'm Sarah Humphrey. I'm a GP by background with an extended role in older people, and I'm the Associate Clinical Director covering frailty, dementia and learning disabilities for the Health and Care Partnership. When Sarah gets to her bit, I will let her introduce herself as well. So what we're going to do today is cover, first of all, some facts about Bradford, about our use of antipsychotics. We're going to learn a bit about what causes distress, why we think there's an issue with antipsychotics, tell you a bit about an audit in Bradford that we did, then think about how do we de-prescribe them, and then tell you what kind of support is available in the district. So let's start with some facts. There are roughly 5,000 people in dementia in Bradford living with dementia, and just under 15% of those have been prescribed an antipsychotic in the last 6 weeks. And that compares to 9.2% nationally across England. And what we found was 63% of our prescribing, so quite a lot, is in care homes. Now, I put a quote at the bottom here from NICE, and I want you to bear this in mind throughout the presentation. A person with dementia should only try an antipsychotic if they're at risk of harming themselves or others, or are severely distressed. The antipsychotic should be tried alongside other activities to try and help their distress. So I told you about that 15.2%. Well, these are the this graph shows you all the other places across Yorkshire and Humber. So we've got our ICB over on the right hand side, and we're the highest there with a big red column. And in this instance, I want you to think of high not being great. High is actually poor. So we're the highest in our ICB area. And then we're the highest across Yorkshire and Humber. So definitely not a good thing for Bradford. And we're, again, comparing that to the national average of 9.2%. So that's my first take-home point. In Bradford, we prescribe antipsychotics to over 15% of the population of people living with dementia. And that includes all stages of dementia, people living in their own home and care homes. So when I gave you that quote from NICE, it talked about distressed behaviour. What is it? Well, people with dementia can become distressed, which leads to such symptoms as aggression and agitation. These behaviours can have many causes, such as pain, delirium or inappropriate care. And I'm going to go into this in a much more detail. And if we understand those behaviours and address those, before we think about giving any other treatment, we can avoid harm. Why do we see distressed behaviour? And why do we see it particularly in people living with dementia? Well, when the brain struggles to cope, and if you have dementia, your brain is already affected, so even more likely to struggle to cope, your brain, that will come out as a symptom called distress. That's how the person feels it. What we see as carers, be that professional or family, or people working with people living with dementia, they see that as a behaviour that they find difficult to manage. But the distress is how the person is feeling. So what I want us to do is change our mindset from talking about challenging behaviours, which is how we feel. And we have to admit it is sometimes challenging. It is challenging to support somebody who is distressed. But that's how we feel. But what I want you to talk about is distress behaviour, and that's how the person living with dementia is feeling. So take home point number 2. We need to rethink challenging behaviour and see it as a sign of distress. Now, this is a busy slide, but what I hope you'll do is take these resources home with you and that you can look back at this. What causes distress in somebody living with dementia? Well, it's got multiple causes. And the reason why I put these multiple causes down is because I want people to think about what could be the cause going on when they look at when they meet somebody who is distressed. So you can feel disorientated or frightened. They may not recognise the place they're in. That's worse if you change environments, go into a new environment, or you have visual problems. Or you may feel disorientated and frightened if you don't understand why things are happening. So if somebody woke me up at 7 o'clock in the morning and started to undress me without telling me what they do, I would be pretty distressed. And so often it's about disorientation and being frightened. People can be anxious or depressed. People often believe that people with dementia don't get anxious or depressed, but they do. And that leads to even greater levels of distress. They can have an unmet need. They can be hungry, thirsty, too hot, too cold, in pain, needing to go to the toilet, needing to just stretch their legs, or they can be bored. They can have changes of routine leading to distress. So we often find things like Christmas and lots of visitors and things, actually great for the visitors, but actually changing routine and can be overwhelming for the person living with dementia. And things like hospital appointments when you weren't expecting them. Transitions of care, and this basically means going from one care setting to another. So in and out of hospital, they first going to hospital, let's say they've broken something, going to hospital, and actually that transition means that they're disorientated, they're frightened, they've gone, and they don't understand what's happening, and that comes out as distress. Going into a new care setting like a residential home. Sundowning, this is when people feel more confused and distressed in the evening and the twilight time. And then something about past events. So people living with dementia have often had the same traumatic experiences as others. So things like war, terrorism, serious accidents, abuse. And they can remember those as their dementia progresses. So the same life events that might distress anybody else are just as likely to occur in somebody living with dementia. And finally, delirium, an illness which is where an illness causes confusion and fear. And all of these things can be the cause of somebody's distress. So those are the causes. And how might that present to other people? Well, people might be aggressive, they may be anxious, apathy, where they can't bother to do anything, they may be agitated, depressed, they may see things and hear things, they may have sleep disturbance, they may become frustrated and angry, and they may behave out of character. I know that when I get anxious and distressed, my sleep goes. I have terrible night's sleep. So that's my presentation of my distress. So if those are the causes and that's how it presents, what might you actually see? What might you actually experience as a carer or somebody being near somebody who has distress? Well, you might hear them shouting. You might hear people crying. You might hear them groaning, using offensive language, calling out, asking to go home all the time, even if they're already home, behaving aggressively, pinching, nipping, hitting, appearing agitated, so pacing, fidgeting, trying to leave, or becoming really withdrawn and uncommunicative, sitting really quietly when that's not normally them. And the other one that's I've got a mindset and have a bit of a bee in my bonnet about is this thing when people talk about wandering, I want you to think of it as walking with purpose. So when people walk up and down, they're walking with a purpose. They're often distressed, and we often describe it as wandering, but talk about it as walking with purpose. And then finally, getting up and down out of a chair or bed. And often what we see is people trying to get people to sit down again and actually rethink of it. Why they're getting up? They're distressed. So what can you do to reduce the risk of distress? I mean, I put dementia-friendly environments. It covers loads of things, but it's basically having environments that are thinking about the person living with dementia. We know some things make people more or less disorientated. So, just having clocks and calendars telling people what time it is, who you are, where the toilet is, so they can find things. All contribute to dementia-friendly environments. Knowing the person and their life story and their triggers and sharing that with staff. So everybody knows the person. It's a bit about what those previous traumas are. Routines help. Simple things like ensuring that glasses are worn, teeth are in, and hearing aids are worn so that people can see, hear, and take part. Orientating, giving information. So when you're caring, not just doing to somebody, but introducing what you're going to do and who you are, reminding them. The next one is hard. Time to care, never an easy one. But that is just taking that time over that when you're doing a supportive caring role, just so that to orientate, giving them time so you're not rushing people will reduce people's distress. Regular routines for hydration, that's drinks, food, toileting and pain relief. Don't wait till somebody looks to be in pain, but offering it and thinking about it. Think about unnecessary interventions. Now, this is particularly in clinical settings like hospitals. Doing somebody's blood pressure, waking them up at 7 o'clock in the morning every day to do something, if you're not going to do anything with the result, is an unnecessary intervention. And if any of you have had your blood pressure taken, it's sometimes not very pleasant. So think about what you're doing and do you really need to do it? An important one is knowing when to walk away and try later. Do you need that observation or that thing at 7 o'clock in the morning, or could you come back at a better time so that and it's less likely to cause distress? And then always think about pain that can trigger for distress and plan for it. And then I always say to people, consider your own emotions and distress. When we are hungry, angry, late or tired, we rush. We're more likely to be distressed by dealing with and supporting people with distress, and that comes across in our own emotions, and then people pick up on it. So how can you manage it when it comes along? First thing is just stop and think. What's causing this? Look for a cause. Try and stay calm, maintain eye contact, and explain what you're doing and what's happening. Reducing overstimulation. We all find it, don't we? When the world is overwhelming, we get more likely to get distressed. So think about, reducing the noise, taking people out of away from crowds, and just reducing that overstimulation. Distraction can be good, so music, movies, photographs and talking, but not if it's overwhelming. So try and use those, but with a purpose. Music or gentle hand holding, but know whether the person likes to have their hand held or not. Distraction, offering a cup of tea or food, can be a way of just diverting somebody. Think of a change of scene, taking somebody out of that setting, let's say from a day room into a bedroom. And then if really somebody is very distressed, give them space, come back later. So there is always things you can do, and it's just thinking of those. And people who work and do this all the time will be doing that instinctively. But if it's new to you, thinking about those things is a good idea. And they're always a good thing to talk about with families who may be new to a situation, to support them and how to manage it. So I've talked about distress, and the big elephant in the room and the why we're talking about distress is really because of our high anti-psychotic use in Bradford. In 2008, Professor Banerjee carried out an independent report into antipsychotics of people living in England. And what he found was they were used too frequently and that the benefits were likely to outweigh the risks, and that roughly just under 2,000 additional deaths a year occurred in people living with dementia because they were on that treatment. So additional deaths that shouldn't have happened. There is no denying that some antipsychotics can help in certain situations, but I'm showing you this because I want to tell you when those certain situations are. So drug trials have shown that risperidone has a small but beneficial effect in people with aggression and to a lesser extent psychosis for people with Alzheimer's when it's taken for 6 to 12 weeks. So that's a very narrow little window for a very specific time. They do not help with distress or anxiety during personal cares, restlessness or agitation, and those symptoms need a more personalised approach. Which antipsychotics can be used? So there are only two that hold an approved licence. One is risperidone, aggression in Alzheimer's, where the aggression is such that it poses a risk to the person or they have not responded to non-drug treatments. And then haloperidol for persistent aggression and psychotic symptoms in moderately severe Alzheimer's and vascular dementia, again, where non-pharmacological, non-drug treatments are ineffective and there is a risk of harm to self or others. So it's a very high bar. There are other antipsychotics used, and we use those what we call off-label, which means the doctor can prescribe them if they have good reasons for doing so under the rules of the General Medical Council. And that is equally the same for non-medical prescribers. They've got to have a very good reason. They've got to be able to justify it. So my take-home point number 3, antipsychotics rarely help any of the symptoms that we commonly give them for. And the reason why we get so worked up about antipsychotics, and we said go back to that Banerjee report, is that they increase the risk of death, stroke, sedation and drowsiness, infections, falls, blood clots and ankle swelling. They can worsen the other symptoms of dementia, and they can lead to what we call Parkinsonism, which is shaking and unsteadiness. So there aren't very many benefits and there are a lot of side effects. I thought I'd put this paper in because it is one of the most up-to-date papers published, and it came out in April this year in the British Medical Journal. And what it said is there are higher rates of stroke, blood clots, heart attacks, heart failures, fractures and pneumonia and acute kidney injury in people who are given an antipsychotic with dementia, and that risk was the highest straight after they started the drug, so in that first short amount of time, and that we should be extra cautious in the early stages of treatment. I put you 2 infographics here, and these are really useful way of showing other people, whether that's families, carers, other professionals, the effects that antipsychotics have. So on the left-hand screen, what you'll see is if 1,000 people with dementia take an antipsychotic for 6 to 12 weeks, 8 of them will have a stroke, whether they're on an antipsychotic or not. But an extra 12 will have a stroke because you've put them on that drug. The same goes for dying. 22 people will die out of that 1,000 in that 12 week, whether they're on that drug or not. But an extra 11 people will die because you put them on that drug. So you can see now that you're really on those scales trying to weigh that balance of what you know now about distress and what you know about the risks of antipsychotics. So that's my take-home point number 4. They lead to harm and do not help the symptoms of distress. We did an audit in Bradford where we looked at lots of the primary care records of people on antipsychotics living with dementia across the whole of Bradford. And what we found were people often on antipsychotics for many years. We don't often attempt to stop them. We find it very hard to de-prescribe. We're all very worried about de-prescribing, even when we think they're not working. They're often started to a delirium that's resolved, but continue them. Virtually nobody had a management plan to say when and how they should be stopped. And it very rarely suggested who should take responsibility for the prescribing and the reviews. We found that the majority was started by our mental health colleagues in the care trust, with the assumption, I think, that somebody else would stop them, but they never were. And the vast majority of our prescribing takes place in care homes, which is now where we focus our effort. So that's the take-home point number 5. We are the barrier to reducing their use and deprescribing. So this last slide of mine is, what should we be asking ourselves before we prescribe? And if you are a prescriber, if you can't answer all these questions, I would say pause, stop, get help. So why is the person being prescribed it? Absolutely nail what you're hoping why you've done it. What symptoms are you hoping that it will help with? What are the possible medical causes of their symptoms? Have you excluded things like pain or constipation? What else have you tried first? What can the carer do to help? And think about, do you know that person as an individual? How will you know if the drug is working? What are you hoping to achieve? Have you explained the side effects to the carers? And if somebody had capacity, to the person living with dementia and their carers, so they understand a risk and choose to take that risk with you. What is the plan to come off them after that 6 to 12 weeks? And when will you be reviewing that drug? And all patients now started on an antipsychotic, coming out of the care trust, should come out with that management plan, and we put a little version of it in the bottom corner. I'm now going to hand over to Sarah Mitchell-Gears. I'm going to be her Chris Whitty, so you'll hear her saying that next as I move on the slides. And Sarah's going to tell you a bit more about all the resources we've got for you.
Thank you, Sarah. For those of you that don't know me, I'm Sarah Mitchell-Gears. I'm Principal Pharmacist at Bradford District Care Trust, working in older people's mental health. So thank you for having me to present to you today. So here on this next slide, Sarah's just put up, there's some resources that are showing us the appropriate prescribing and also deprescribing. So if you go into these resources, there's sections on prescribing and deprescribing antipsychotics, and lots of tools that will help you to implement deprescribing regimes if that's what you're looking to do. And there's a QR code and a link there that will take you to that resource. So next, please, Sarah. Thank you. So as Sarah said, when we're reviewing antipsychotics, we should be using the lowest effective dose for the shortest possible time. We need to review every 6 weeks, and we should actually only be prescribing for 6 weeks if we're using risperidone, because that's the licensing time for it. And in practice, for inpatients, we would review inpatients in hospital every 1 or 2 weeks, and patients in community every 6 to 12 weeks. That's what we like to do. But obviously, as Sarah said, that doesn't always happen, because we are finding, and they found from the audit data in Bradford, that people, particularly residents in care homes, had been on antipsychotics for months and sometimes years. We should be stopping the treatment with antipsychotics if the person is not getting any clear benefits. So don't use it if there's no point using it. But in order to stop them, we need to take them down slowly, which is something that I'll come to on the next few slides. And as it says there, unless there's a severe risk or extreme distress, then the default measurement is to continue the antipsychotic with monitoring, ongoing assessments, and continuation of non-drug treatments, because non-drug treatments are very important in managing distress, as Sarah was saying in the early slides. And we should remember it's never too late to review. So if someone's been on antipsychotics for months and even years, it's not too late to implement a review and to start to look at the measures that we can take to try and reduce the treatment and withdraw that antipsychotic slowly. Next slide, please. So antipsychotics can be withdrawn without significant detrimental effects to behaviour in around 70% of people. So that's showing that there's a large number of people out there that are not receiving any detriment, they're not experiencing any detrimental effects by withdrawing the antipsychotics. And as I said, it's important that we regularly assess and the antipsychotic is stopped slowly and gradually if it's no longer needed. And as I said, there's plenty of deprescribing tools out there. The one in the resource that I just showed you on the previous slide, there's lots of other information and there's some references there that you can go to have a look at the information that's out there about deprescribing antipsychotics. Next slide, please. So take home point 6 is that the world will not turn upside down if you reduce the antipsychotics slowly in people living with dementia, and it's definitely worth giving it a go. Thank you. Next slide, please. So this is what we're currently doing. So Sarah did an audit of the antipsychotic use in Bradford and found that the use was very high, and the source of the antipsychotic use was in care homes, which is where we needed to concentrate our efforts. So we've embarked on another audit at the beginning of this year, which is going to take us through to 2025. And this is looking at antipsychotics that are being used for BPSD, specifically in residents in care homes. So there's a small team of people, myself, Sarah Sheard, who I'm hoping is on the call today, and a nurse called Carol Eagers. And we are working together to actually explore the use and try and taper down and reduce the use of antipsychotics in these residents that don't actually need them anymore. So what's happening is Carol's going into the care homes and doing the initial assessment, and she's speaking to the staff and identifying residents that are suitable for deprescribing. And then I'm following the follow-up visit, again speaking to the staff, looking at the information on System 1 and whether it's actually appropriate to withdraw those antipsychotics. We're also taking data as to how long they've been on them, whether they've had reviews, who started them, whether they've been reviewed by the GP surgery, whether they've been started, like we said, by the community mental health teams or by the care trust. And in some cases, we are recommending that people are reduced, and we're trying to stop these antipsychotics. So on our first visit, we're giving the care home a relative information leaflet. This explains a little bit to them about what we're doing, and we're asking the staff at the care home to give this information to the relatives when they visit, so that they are aware of any interventions that we're making. And as it's very important that everybody's on board with this. So it needs to be done holistically. We need to involve the carers, we need to involve the residents in order to be successful. Thank you, Sarah. Next slide, please. So this brings us to take home point 7. And that is that you're not alone if you're wanting to take on some deprescribing or looking at residents that in your care home that might benefit from coming off their antipsychotics. There's lots of guidance and lots of people out there that can help you. And it's also important to have a really clear reason why you're doing it. And as I said, develop the communications channels with the family, the carers and the patient, because it's a big key to success if everybody works together on this. Thank you. Next slide, please. So my details are there, and Sarah Sheard, who is also involved in this deprescribing audit. If you have any queries, obviously get in touch with us, and Sarah Humphrey's email is going to come at the end of the presentation. So that's just to let you know who's involved in the deprescribing audit. Useful resources on this slide. You may have seen these before, but there's links to both those documents. They're very long, but there's a lot of useful information there about local groups, local activities, places that you can tap into, websites you can look at if you need any support about anything to do with behavioural and psychological symptoms of dementia, not just antipsychotics. Thank you. Next slide, please. And this is just to remind you, I don't know whether you're familiar with this, but the clear training for care home staff is absolutely excellent. That's out there and available for your staff if you're here from a care home. Thank you, Sarah. And I think that brings us to the end of our presentation. So thank
And
you everyone for listening. Our emails are at the bottom there.